Welcome to this episode of The Meaning Mindset with Rabbi Ron. I'm delighted to welcome a dear friend and somebody whom I have enormous admiration for. That's Dr. J. Patrick Whelan. Let me tell you in brief, narrow a very long and extraordinary resume to a paragraph so you'd understand a little of Dr. Whelan's accomplishments. Dr. Whelan is a distinguished pediatric rheumatologist affiliated with UCLA Health. He holds a biochemistry degree from Harvard University. He holds a PhD from Texas Children's Hospital and an MD from Baylor College of Medicine. With over 2 decades of experience at Massachusetts General Hospital, Dr. Whelan's expertise lies in non-inflammatory vasculopathies. His research and clinical work have provided valuable insights into the mind-body connection, and he continues to be a pioneer in this field. There is a lot to learn from Dr. J. Patrick Whelan. Let's join him now for this episode. It's a pleasure to see you always. You're one of the most fascinating people that I know. I've really enjoyed our coffee conversations. And I remember the person who introduced us was Maestra Dr. Noreen Green, a great musician. And I never realized your medical training background. I just thought that at that point that you had a background and interest in music. So I've learned how multifaceted your life is. Let me ask you, before we go into any details of anything, to describe the work that you do.
Professionally, I am a pediatric rheumatologist at UCLA. So we're kind of the consultants of last resort. So we see a lot of children who have unusual things that have seen a lot of other doctors. Mostly it's an arthritis specialty, but I run a specialty niche clinic at UCLA for children with PANDAS syndrome, which is the pediatric autoimmune neuropsychiatric disorder related to strep infection. And this is a condition that affects a lot more children than people think, but they typically have the abrupt onset of obsessive compulsive disorder and tics, and sometimes oppositional defiant kind of and emotional lability features as well. So these are kids that can be a holy terror, and sometimes they just completely take over their family's life. And you might ask, why would a rheumatologist see a patient like this? And the reason is because rheumatic fever is one of the defining illnesses in our specialty. And rheumatic,
to this day?
It is a specialty that is relatively young. It's only been around for about 100 years.
Okay.
And rheumatic fever, of course, has been around since antiquity.
Sure.
And 100 years ago, children with rheumatic fever often died. So it was one of the leading causes of death of elementary school-age children 100 years ago. And rheumatic fever is a post-streptococcal disorder which causes OCD and tics, but it also is associated with heart valve problems and arthritis and fever. So it's still a major disease problem in the rest of the world. There are about 350,000 deaths every year in other parts of the world, but it's almost completely disappeared here in the United States. So it's created this interesting situation where this condition that I treat, which has some overlap with rheumatic fever, is nonetheless something that never itself turns into rheumatic fever. So these children never develop heart problems. And so a lot of the neurologists and psychiatrists are kind of skeptical of the diagnosis. And so that creates some interesting problems. Like, for instance, I'm the only doctor in Southern California that takes care of children that have this problem.
And how do you differentiate when a parent presumably sees behavior, doesn't necessarily link it with an illness because it was just strep throat? Our kids had it, we had it. I don't know that I ever had any sense of alarm in terms of what it might manifest as. So the parent comes to the physician and they treat strep as strep. Then you're saying there's sudden onset change in behavior. And who makes that linkage these days in the general hospital and pediatrician's clinic?
So this is an interesting dilemma, I think, for every parent, is trying to define that line between what's normal behavior and what's abnormal behavior. And oftentimes these kids start out with these very subtle features, like they can't wear certain kinds of clothes, or all of a sudden they refuse to wear any clothes. Or another big subpopulation of the group have what's called ARFID, which is a restrictive eating disorder that looks like anorexia. All of a sudden, they just can't eat. And one of the reasons, for instance, that we see is that they're fearful of swallowing their saliva because they get it in their minds that they have contamination, the bacteria in the saliva, and they're afraid that it's going to get into their stomach and cause some kind of
So
health
really
problem.
it's what we think of as OCD behavior.
Yeah.
Looking at the population that has OCD, and I know friends of mine, people in my community who treat OCD, are they linking it to strep? Is there an awareness in that therapeutic community of this linkage, or is it still somewhat unknown?
Well, OCD is kind of a strange animal because it was long thought to be an anxiety disorder, and recently it's been reclassified in the DSM-5
Sure.
as a whole separate category of disease. It's more common in adults than it is in children, although in retrospect, a majority of adults that have OCD had symptoms when they were a child. And the population that I see are different in a variety of ways. They're distinguished by the fact that there's an abrupt onset. The vast majority of them don't have a typical strep throat history, so there are a lot of other infections that can be triggers for this. And but the common denominator is that it very significantly compromises their social function. A lot of times their academic function and family life just gets turned upside down by it. So,
is it only OCD? You said tics as well. And didn't you say ADHD can come on as sudden onset as well?
there's a lot of overlap with the ADHD, attentional kind of symptoms, the ability to pay attention. And so a lot of these kids have been treated already with ADHD medicines, stimulant medicines like Ritalin, Concerta, and so on. So, and some of these kids, the average child who has this condition, PANDAS, is about 5 years old. So they're really young. But increasingly, as the word has kind of gotten out about the existence of a disorder like this, we've had more and more adults who have contacted us and tried to get in to be evaluated as well. I think part of it is that, they're frustrated with the traditional approaches, which are cognitive behavioral therapy and exposure response therapy, ERP, and then the whole array of medications that are used with their limitations. So, and it's kind of interesting now that Bobby Kennedy has been confirmed as the Secretary of Health and Human Services, and he's been somewhat suspicious of the roles that SSRIs play in the onset of a whole variety of health disorders. So we're going to see how far, that goes in terms of affecting the care and the evaluation of the kind of patients that I'm seeing.
And I wonder how much it'll affect the conversation around these issues.
Yeah, very much.
And the way that physicians and parents maybe develop a new language and different expectations of what their doctors will consider. I wonder if I'm a parent. Well, let me stay thinking about is it PANS and PANDAS? What would you do differently? So let's say you meet a child who's been treated with Ritalin or some other medication, is also getting talk therapy to address the issues of oppositional behavior or attention deficit or tics or OCD. Is there a different intervention at that point that you would say there's still more that we can do if I get a chance to see that kid? Or at that point, are they on a track that can't be treated?
As a rheumatologist, I view my role as kind of a middle ground between the psychiatrists and the neurologists. So I try to think outside the box in terms of other things that may be causing what's going on. And one of the big ones that we found in our patient population, we're following about 700 families now, is that about 2/3 of all the kids have evidence for immune deficiency. So they are more susceptible to infections. They get sick more often than other kids do. And we do a workup to try and evaluate their immune system and see what's going on with it. And so there are certain underlying diagnoses that lend themselves to alternative therapies, which, are a thing apart from using something like Zoloft or Prozac. And so I think when you get closer to the cause, kind of like the whole idea of subsidiarity, when you can get closer to what's actually causing the problem, you are generally more effective at treating it. One of the other interesting subpopulations that we've been seeing is that about 40% of all the kids that have a PANDAS diagnosis eventually develop some features of a kind of arthritis that's known as the spondyloarthropathies. So these are things like psoriasis-related arthritis, psoriatic arthritis, Crohn's disease-related arthritis, for instance. And so we've had quite a few kids who presented to my clinic with behavioral symptoms, and then they ended up walking out with a diagnosis of ulcerative colitis or Crohn's disease, which is a completely different kind of a treatment. Wow. And then their behavioral symptoms respond to that. So I don't mean to poo-poo in any way the effectiveness of cognitive behavioral therapy, which represents a revolution in its own right for the treatment of kids that have these kinds of problems. In fact, it's interesting that studies with magnetic resonance imaging, functional MRI of the brain, which show the hyperactivation of a certain area of the brain in the front of the brain called the orbitofrontal cortex in kids with OCD. If they are successfully treated with cognitive behavioral therapy, you can show in the imaging that it physically changes the circulation to that part of the brain.
Wow. It changes it permanently? Creates a lasting change?
It does, yeah.
Really?
Yeah. So, and the statistics generally show that about 2/3 of kids who have OCD with cognitive behavioral therapy and ERP after a 3-year period go into remission. So there's a really substantial improvement. It's not a permanent kind of a thing in most children like it often is in adults. And I'm sort of peeling off a whole nother subgroup of kids that have other biological explanations for what's going on. You asked an interesting question before, which is the relationship between OCD and tics.
Yeah.
And there's really an interesting connection between them, and it's not obvious to most of us what that connection is. But when you look back into the ancient evolutionary past of the brain and primitive mammals trying to discern what was safe and what was dangerous in their environment, we developed this whole apparatus that is very centered on our emotional life, which resides in a part of the brain called the basal ganglia. And part of it is involved in the assessment of, sounds that are safe sounds, like the bubbling stream, for instance, as opposed to the roar of the saber-toothed tiger. And the response to that kind of stimulus for, our primitive relatives was to be able to look quickly to one side or another to gauge, what the threats were. So tics represent involuntary movements in response to certain stimuli to that very primitive part of the brain. So it's interesting that these patients have a dysregulation, both of the assessment of threats in their environment with things like auditory processing, and also their response to threats, which is what tics in some respects represent. And if I may share one last thing, which is that you and I became acquainted by virtue of our mutual interest in music. And music provides an incredible crucible for understanding these very primitive instincts that we have in our brain. And so that takes me into another aspect of my career life, which is I teach 2 courses that have been a source of great joy to me, one of which you have visited as a lecturer, and it's called Music and the Mind, and it's a Harvard Extension course through Harvard University. And it's really focused on the evolutionary origins of our musicality. And there's just a fascinating overlap with what I see in my patients who are suffering from these kinds of behavioral and emotional issues, and what music has to teach us about how the brain works and how we came to be human in the first place.
So I can't leave that alone because I'm so interested in it. what's first? I mean, I'm thinking about, is music the thing that creates the response in the brain, which is a threat or calm safety response? And then one of the things that comes to mind, as I know you used to conduct choral music as well, and I came from a classical background, is, has the name music remained the same, but the effect of music changed over the millennia as we've developed into rock and roll and punk rock and all the different styles of music that no longer have the same effect on the brain?
Part of the way I think about this is with the duality of language and music. And they're obviously related closely to one another because there are no other animals that have both of these things. And the evidence suggests now that the two capabilities co-evolved and initially came into the human experience around the same time, sometime around 50 or 60,000 years ago. So, and it's interesting too that it co-evolved with other humanoid species like the Denisovans and the Neanderthals, who clearly had a musical capability as well. So a lot of the science that's been done on this has focused on things like what Darwin focused on, which is that he viewed music as a proto-language. It was sort of an echo of an earlier time in human evolution when we didn't have these sophisticated symbolic languages, and rather, the grunting and groaning elements of human expression, which are more reminiscent of the emotional content in music. He viewed that as sort of representative of the way that our more primitive ancestors communicated with one another.
So maybe there was a certain aggressiveness in ancient music, pre-ancient music, meaning groans and grunts and bangs didn't necessarily give you a sense of Mozart, of calm, or of alignment in the brain. But do you feel like different music has, I presume it's been measured and seen a different effect on that tic response, that threat response?
So that is a very complex question, because what my course focuses on is this larger issue of, is our musicality something that evolved in a specific way to help us, to the extent that every culture in the world has music, that making music has a price to it. And when we're making music, presumably we're not hunting and gathering.
Sure.
And so
we're on our phones these days.
So it's interesting that, you can go way back and, in human philosophy and human history, and people going even back before Plato were grappling with this issue of, why are we musical? Where does music come from? And Plato thought it came from the heavens. And he felt that it was so powerful emotionally that only the most virtuous members of society could be entrusted with the job of being a music educator, which I think is fascinating. And then, of course, when you move forward through the work of René Descartes and Jean-Jacques Rousseau, these great thinkers, who helped usher in the Enlightenment, they both were fascinated with music. And in fact, both of them started their careers studying the physics of music and what is sound after all, and why does it have this control, this power over us. And Descartes ultimately articulated this idea of the duality of human mind, that the mind or the soul is distinct from the brain, which controls and pulls the levers.
That's functional.
Yeah. And I think that more recently, we've grappled with this from the standpoint that you're addressing, which is, can music be used in some way therapeutically? And just in the last 70 years, there's been this enormous revolution with music therapy, with degree programs and journals and meetings and so on. And now I think it's clear that music therapy can have an enormous benefit for certain kinds of illnesses, including dementia and Parkinson's disease, movement disorders, and children who have developmental problems with autism, for instance, and Williams syndrome. So these are things that I'm very interested in, both for my own patients and also in the context of these courses that I teach.
You're a rheumatologist, and you have such a wide array of interest and expertise. Is it typical of a rheumatologist to be having this kind of conversation? I don't mean at a podcast, but to have such a wide gamut of ideas and theories and practice and experience to pull together.
I would say that by and large, rheumatologists are people with wide interests. A lot of them that I know love music, for one thing. Rheumatology as a specialty is distinct really from all of the other subspecialties because we transcend all of the organ systems of the body. So it's not the cardiologist who's just focused, on the circulation and the endocrinologist who's focused on the glands. We're more like the infectious disease doctors who are looking at things that are happening in all the parts of the body. So I think that rheumatologists by their nature are more Renaissance oriented that way. Trying to think outside the box and, grapple with questions that haven't been forthcoming to the general practitioners.
How did you choose this practice, this specialty? You were at Harvard for undergrad and then at Baylor, am I right?
That's right.
For your doctorate and for your PhD. What drew you to this field?
Well, I grew up in a very musical family.
Yeah.
My father was an opera singer and my mother was a concert pianist, and they used to stay up late playing the piano and singing together. And they were both very accomplished accordion players, which was kind of interesting. And my poor mother developed rheumatoid arthritis in her 30s. And like for many young women, she really lost the use of her hands. So her ability to play the piano, was severely affected. So it was something that weighed heavily on me. And when I came to thinking about my own career directions, becoming a rheumatologist was very appealing to me. So I got a job after college working in the rheumatology department at Brigham and Women's Hospital in Boston, which is, one of the great Harvard teaching hospitals. And ultimately gained access to a scholarship position at Baylor College of Medicine in Houston. And so I was in the MD PhD program there. And I had the privilege of doing my graduate work under an amazing man whose name was Bill Shearer. He was an immunologist his claim to fame was he was the doctor for David Vedder, the boy in the plastic bubble.
I was just thinking, yeah.
And he was one of the pioneers in developing AIDS care for children and also for trying to figure out how to help children who were born with these severe immune deficiencies. So my career has sort of moved in some unique directions, but the thing that sort of ties it together is that immune deficiency predisposes to all sorts of different conditions. And in fact, since the time I started studying, as a med student, the whole paradigm for autoimmunity has completely changed. It used to be that people thought that our immune system resided on a spectrum from too much to too little.
Okay.
And if you've got too much immunity, you get autoimmunity like diabetes or thyroiditis or arthritis. And if you had too little, you just got sick all the time. But it's turned out more and more that all of the different forms of autoimmune disease, including PANS and PANDAS, are themselves manifestations of compromised immunity. So the immune system really impacts us in all sorts of remarkable ways. And now I think increasingly there's an interest in degenerative brain diseases, including, Alzheimer's disease.
And Huntington's and the others.
Huntington's chorea and frontotemporal dementia, which it's turning out there's an immune dimension to those conditions.
Really?
And that's sort of an explosive area right now of research. I hope that our research enterprise in the United States continues to be as exciting and forward-looking as it has been for so many years.
There's another one. There's where the brain essentially folds on itself. Prion disease. Is that a related issue?
The prion story is a fascinating, unique story that's tied into something called Creutzfeldt-Jakob disease. And there's a old researcher named Stanley Prusinger who appreciated the connection of a non-infectious not an organism per se, but it's a protein which can communicate this disease from one individual to another. And so I think it was Maori populations. He traveled to the South Pacific and appreciated that brain tissue from one individual that was consumed by another could communicate this disease. So it's a degenerative disorder, and it's given us a variety of new insights into how other degenerative brain diseases occur.
So you're saying cannibalized brain tissue?
That was part of his legacy. Yeah.
Thinking about this, I talked to my wife about this on a long drive a couple of days ago. I feel like we keep hearing about autoimmune diseases, immune issues, more than I've ever heard before. Everybody seems to have some issue with their immune system. Everybody, great exaggeration, but so many people do. Is there something new in our world or in our reality or that we're consuming or in our environment, or do we just now have language for something that always existed that we never spoke of?
So this is a great question that, and I think Bobby Kennedy is asking some of the right questions. Why is the autism rate rising the way that it is? Why is our obesity epidemic so terrible now compared to what it was 50 years ago?
Yeah.
What does it take to make America healthier again? And the immune system is a very highly dynamic organism unto itself. It's an incredible capability that we have to recognize organisms that have never been introduced into human populations in the whole history of our evolutionary history. And yet our immune system has the capability to recognize those things, to mount a response against them and help us to get over them. But invariably, because we represent this tremendous genetic diversity in our population, different people are going to have different capabilities with regard to protecting themselves against a whole variety of different threats. So the obvious example is what's gone on with COVID-19.
Right.
And the coronavirus was derived originally from bat populations. And setting aside the whole issue of where COVID-19 actually came from itself, it's such a unique virus because it, in some respects, never actually gets into our body. It infects cells in the nasal epithelium, and then it manages to sneak through the respiratory tract down into the lungs, and it creates this detritus with the spike protein that's a genetic product of the virus. And by virtue of the fact that it stays out of the circulation, the immune system doesn't ever have a chance to really grapple with it. So part of the success of the vaccine effort against COVID-19 was finding a way to sensitize the system and empower it so that the individuals who are at the greatest risk for severe consequences of COVID-19 could be protected against it. There's a lot of controversy about it because the vaccines obviously don't do a very good job of protecting us against getting the virus in the first place.
Right.
And I took care of many patients myself who had been vaccinated and still developed severe COVID-19 later. So anyway, the whole COVID-19 field has been an incredible opportunity to understand how the immune system works, and things, for instance, like the fact that the coronavirus actually impedes the ability of our T lymphocytes to function normally. It shares that with the measles virus, for instance. If you get a measles infection, your immune system is never quite the same. And we know now that the whole long COVID phenomenon, for instance, at least in part, is caused by the fact that when the coronavirus gets into our system, it impairs the ability of our white blood cells, our T lymphocytes, to control infection with other viruses, in particular the Epstein-Barr virus, which is the mononucleosis virus. So COVID sort of unlocks the ability of the mononucleosis virus to be reactivated, and people develop these fatigue symptoms. So anyway, it's the Wild West out there with regard to all these different organisms that our immune system has to protect us against day in and day out. And especially if you're a child, in a daycare environment, for instance, or in our schools, which are, increasingly crowded.
Right.
Kids are exposed to just all sorts of organisms day in and day out, and we don't even think about the fact that our immune system is there doing it for us every day. And there's going to be a lot of variability from one child to another in terms of how it affects their overall health.
I read your address, and I don't know if it was a transcript of what you said at the House of Representatives or something you submitted, but you were talking about the possible long-term effects of the COVID vaccine on young kids. Were they, I'll call it normative, healthy kids, or you're saying particular kids with particular syndromes or health challenges might be adversely affected in the long term?
In 2020, I chaired a study group at the American College of Rheumatology, and I realized that there was something really unique about the new COVID vaccines that were under development at the time, because they were employing the spike protein from the virus, which is the same thing that actually causes all the damage during natural infection. You probably can't think of another vaccine that we receive in our lifetimes where the dangerous principle is itself employed in a way meant to help protect us. So for instance, when we get vaccinated against tetanus, the tetanus toxin is inactivated and turned into a toxoid, and then it's given to us as a vaccine, and it stimulates an immune response. So I was concerned about the possibility that these vaccines, which everybody was very anxious to have approved as soon as possible, that if we rushed into the production of them, that there were invariably going to be some adverse consequences. And so I wrote a letter to the Food and Drug Administration that was published at the beginning of 2021, where I warned about the possibility of developing myocarditis as a complication of these vaccines. It did turn out that there was a higher incidence of heart inflammation in young men who were vaccinated with the coronavirus vaccines. And I subsequently joined an epidemiology group that brought together a number of experts around the country, and we reformulated all the data from the original vaccine trials with Pfizer and Moderna to look at what the actual incidence of the severe adverse effects was of the
specifically
vaccines.
On the heart.
Well, on the heart, and it turned out that there were a broad array of complications that occur. These vaccines are not easy to take. They are hard on the body, comparable, I would say, to the smallpox vaccine, which nobody gets anymore because smallpox was eradicated, 75 years ago. And so what we tried to do was quantify how hard these things are on the body. And I was invited to come and testify before this House Select Subcommittee on the coronavirus in Washington last March. And in particular, I ended up talking about a patient of mine, a young patient, a 7-year-old boy who got a vaccine, and then he ended up having a cardiac arrest the next day. He had an unusual developmental condition, but I think that the point that I was trying to make is that one size doesn't fit all, that we have to take into account the differences that exist between different individuals. And some individuals, like if you're an 80-year-old man who smoked, you're going to be at a lot higher risk from getting a coronavirus infection than your average middle-aged person, although there were a lot of middle-aged people who ultimately suffered severe adverse consequences of getting COVID. And, in the case of children, we pushed to vaccinate all the children, but virtually all of the kids who ended up being hospitalized and the few hundred who ended up dying across the entire United States were almost all kids with a high BMI. So there was something about obesity that lent itself to adverse responses to the coronavirus.
I would assume that the public would assume that. We'd say, because we have an assumption that obesity is an unhealthy lifestyle, unhealthy diet, so that person is therefore has a greater predisposition to illness. But that's naive, essentially. You're saying there's something very specific related to obesity that linked itself with people's outcomes with COVID.
Yeah, and we know a little bit about the reasons for that now, because this virus binds specifically to a protein that's highly expressed in the vasculature of our fat cells. So people that have a much greater representation of the lipid containing cells in the body, the fat cells, just have a lot more fertile field for this virus to land, to replicate, to cause trouble. And I think this was an interesting problem because we didn't want to stigmatize heavy children. Right. And the recommendation was just vaccinate all the children. So I don't know if in retrospect we could have done it more intelligently in a way that wouldn't have brought about a lot of the complications that we saw.
Did we get it largely? Did we mostly get it right in terms of our approach? Or do you think in retrospect, if we were to look at this critically, we'd say we should have taken a different approach, should have taken more time to find the solutions?
I think inevitably, they say experience is what you get when you don't get what you want. And in this case, we learned an enormous amount by what happened. We learned about how to respond to pandemics. We learned how to develop vaccines in a hurry. We learned about communication and miscommunication.
Right.
One of the funny coincidences in my life is that I had an opportunity to take care of Dr. Jonas Salk at the end of his life. And I was doing my medical training in San Diego, and he ran the Salk Institute right down the street. And I had a chance to get to know him during that time. And he was...
What era would that have been?
So he died in 1995. And at the time, he was utterly dedicated to trying to create an AIDS vaccine. And the AIDS epidemic was already 15 years old at that point, and people were desperate. There were no treatments for it. There were no drugs available at the time. People were desperate to make a vaccine. And here was a guy who had made one of the very first influenza vaccines.
Incredible.
And then he created the first polio vaccine. And so he had some wild-eyed ideas about what we needed to do to solve this AIDS problem. And I think he would have been totally shocked to see that 30 years later, we still don't have a vaccine against HIV. But I bring it up in part because there's been a lot of discussion recently about the polio vaccine by virtue of, the Senate hearings for Bobby Kennedy's nomination. And Dr. Salk was so confident that his vaccine was going to be effective that he was very reluctant to have a placebo arm for the vaccine. And in the early 1950s, we went through a roaring polio epidemic where there were loads and loads, millions of children who got infected with the polio virus then. And a certain percentage of them were paralyzed and another percentage of them died. And in the end, the March of Dimes funded a trial that involved more than 600,000 children across the country. And they had 420,000 kids who got the vaccine and about 200,000 controls. And in the end, there were 34 kids who became paralyzed and 16 kids in the trial who died. And all of those children were in the placebo group.
Really?
So when Jonas Salk got up in front of the microphones in April of 1955 and announced that we had a vaccine, there was a very high level of confidence that it was an effective vaccine, and that parents' fears during the summer about their children catching this terrible illness, were finally going to be addressed. But it came at a price, that you had children who potentially could have been saved who died as a result of their involvement.
What a tragedy.
They may very well have died anyway because there was no treatment before that. Yeah. So anyway, but that's sort of an illustration of how our immune system is just, it's very powerful, both at a protective level, but also potentially causing mischief. And, diseases like diabetes and other autoimmune diseases are things that we're working hard to try and figure out now so that we can find ways to minimize the suffering that people experience from this.
You mentioned Bobby Kennedy a couple times, and whatever anybody thinks of him, because he's now a political figure, not just a thought leader, he has radical ideas to many, and I'm sure he has threatening ideas. If you're in the if you're in the food business, if you're in the what would we say, industrialized food business, then you're probably very concerned about him coming into having authority and power and influence. What's your sense of how things might go well with him under his leadership? How might we get a little healthier? Or are you skeptical? That's another question.
I think that many of my colleagues are exceedingly wary about what is ahead of us because of the comments that he's made in the past, about different subjects. I don't share all of those concerns because I've spoken to him on the phone. I think he's a very smart guy. He has a good heart. He worked for years to try and, address a whole variety of environmental problems. And I think that by and large, people would applaud, the public spiritedness of those efforts. His more recent involvement in the whole vaccine issue has raised a lot of hackles.
Of course.
But I think that, he's said repeatedly that he's not against vaccines. He just wants better vaccines. And I think that he's going to learn a lot in the course of these next 4 years. In some respects, I feel that the larger threat right now is having certain individuals who don't have a background in science, who are threatening to cut substantially the amount of funding for biomedical research, potentially for health education for residents and trainees. There are echoes of this that are going to reverberate through the entire healthcare system, not just to threaten our whole research enterprise in the United States, which, say what you will about the efficiency of our healthcare system, we do have the most magnificent research
that you're a part of.
And it's exciting to be a part of. This is a very exciting time to be a doctor and to be treating people because there are just so many new ideas out there and new directions and enterprises and cooperation between private companies and the government. But I think it's also a very fragile enterprise. And so if there were to be dramatic cuts in funding for the National Institutes of Health, for instance, for training of our residents and fellows, it is something that's going to severely threaten the health and well-being of people all over the United States. And then, of course, the whole debate over Medicaid, which some people see as a big cash cow to be able to cut the federal budget. Medicaid is something that serves the needs of vulnerable populations all over the country.
Yeah.
And these are people that desperately need the kind of care that Medicaid provides. And so I really hope that the people in power in Washington, including Bobby Kennedy, will find it in their heart to recognize that, I think even as a spiritual person, we have to find it in ourselves to reach out to the least among us.
Sure.
And, Medicaid is one of the ways that we do that as a compassionate society.
Yeah, I hope so as well. We have to hope that the politicization, not only of health and medicine, but everything, doesn't mean that we can't reverse that where it matters most, when that's the well-being of people. And as you say, there are people who can buy better health care and people who absolutely can't, who are going to community health clinics and hoping that they're going to get the same care that you and I are and bring them back to health. I think about your work with kids and how many of the families that are coming in to community health clinics all over the country are coming with kids who need exactly the kind of care that you can give.
Yeah. And something like, these conditions that I take care of, they are extremely demanding on the providers. The amount of time that I have to spend to write up these evaluations, and I have families that contact me every day with questions and concerns, and so it's a taxing thing on the provider, and so maybe it's not surprising that there aren't any other providers who work in this area in Southern California. It's been made easier recently by a bill that was passed by the California legislature last October, AB 2105 was signed into law by our Governor Gavin Newsom. It obligates insurance companies to cover intravenous immunoglobulin, which is a treatment for the most severely affected children that I see.
I see.
And I used to spend hours every week on the phone arguing with insurance companies, trying to twist their arms and persuade them to cover even just a trial of this drug to help rescue these kids from what oftentimes was total disability. And now the insurance company is not spending money to pay reviewers to deny the drug. Instead, they're just going ahead and paying for it. And it's not a huge cost for them because I'm one of the only providers actually prescribing it for the whole state of California. So I think this is a case of the legislature sort of overrode the wishes of the insurance industry, and it's been to the enormous good of the children who are affected.
What's exciting for you? What's uplifting? You deal with illness and conditions that aren't changing in health. What do you find inspiring other than your teaching, but what particularly in terms of immunology, rheumatology, and all of your medical interests?
I think this is a very exciting time in the cancer world. I didn't mention this before, but I did an oncology fellowship after I did my rheumatology training. And I worked for many years covering our oncology service at one of our hospitals. And one of my interests in that is that the rheumatic disease is not only predisposed to, all this disability, but also to susceptibility to cancer. And this is a golden age right now in the worlds of hematology and oncology. The incidence of unremitting leukemia in children, for instance, is so much better now than it was even when I was going through my training. That's really exciting. And there's been this revolution of personalized medicine in the oncology field, looking at specific mutations in the tumors. We know from the work of Harold Varmus, the former director of the National Institute of Health, that certain genes control the growth and proliferation of our cells, leading to cancer. And to be able to actually sequence the DNA from a tumor, identify the specific mutations that have occurred to develop a drug
treatment
that blocks the gain of function in some of these mutations. So it's a new era of personalized medicine, and cancer is just one of those things, strikes people out of the blue. It seems so intensely unfair.
Yeah, it does.
And I think we have to hand it to President Biden that, 30 years ago, he was talking about the cancer moonshot, and he really put his, the pedal to the metal and pushed a new era of development of personalized therapies. He's not, personally responsible for it, but he lent his moral credibility to this. And I wonder if I could just share with you a story that I told you about, a few weeks ago. I had an opportunity to meet Jimmy Carter one time, and I went to Plains, Georgia to attend his Bible study class. As it turned out, the one that I attended was the last one he ever taught, in part because his health became more difficult after that, but then the COVID pandemic took off shortly thereafter. Yeah. But at that 40-minute talk that he gave to a packed church, he talked about what it was like to have lost all of his own family members to pancreatic cancer at a young age. And he somehow miraculously was spared that fate, that his sister Ruth Carter Stapleton was an amazing, inspiring public speaker with this deep spirituality. And she died in her 50s, pancreatic cancer. And he related how he was down in South America when he was in his mid-90s and started not feeling well. And it turned out that he had metastatic melanoma to his brain. And he said that he had resigned himself to the possibility that this was the end of the road for him and that, cancer had finally caught up with him. But he said, through a miracle of modern medicine, despite having brain involvement with this terrible malignant disease, he was successfully treated and went into remission for it. And during the course of that talk, he shared with the congregation there his reflections on the book of Job. And of course, this is something that I think any religious person in the Western tradition is familiar with. Just the deep unfairness of life sometimes.
And compounded unfairness of life,
And how one thing on top of another can make it seem like the world is just this uncaring, amoral place. And I live myself in the middle of Pacific Palisades, and I've watched, all of these elderly friends of my parents who lost everything in our recent fires here. And what could be more unfair than that?
Right.
And yet, I think that the thing about meeting Jimmy Carter that day that was so inspiring was this sort of calm reassurance that he had lived a spiritual life, that he was the beneficiary of the testimony of credible witnesses over all of these thousands of years, people who, had thought deeply about all these issues and had given us the assurance that there is a God, that God has a stake in us personally, that our lives matter to God and they should matter to one another. And I found it a deeply consoling message. And at the time I was going through a grief experience of my own because I had a younger brother who died. He was an amazing musical theater actor, and I was on my way to New York for a memorial service to him, and I decided to stop at Plains, Georgia. And the thing about it that I think strikes me too is that I told Jimmy and Rosalind Carter about my brother, and about 3 months later I got a letter in the mail from Jimmy Carter saying that we were deeply affected by your story about your brother, and we just want you to know that we are thinking about you and we want to share our condolences. And I'm sure he must have written thousands of letters like that over the course of his career. But it strikes me just in the context of my day-to-day work that medicine really is a very high calling, like the ministry, because you're with people at the most desperately difficult moments in their lives. And hopefully we are there selflessly providing for them whatever gifts we have to make their lives easier. And I think that there's a moral there, that Jimmy Carter lived that kind of life. And I take great inspiration from that myself.
As do I, from you telling this story. I know you and I have talked about faith and faith traditions and wisdom traditions and also the music of religion. Going back to what we glibly call the healing effect of music, what do you think is unique about liturgical music? I think about the great Verdi Requiem, the Mozart Requiem, Hebrew chants, the fact that the Levite priests were singing and playing instruments right from our earliest records. So what do you think that component to religion is and to music is?
This is a fascinating subject, and of course music is an intimate part of virtually every form of worship around the world. And I've thought a lot about that issue. It's one of the subjects that we discuss in my course. And one of the things that I find really intriguing about music is an outgrowth or an extrapolation from work that Noam Chomsky did on the nature of language. And Chomsky is a great linguist, sort of the father of American linguistics. And he had this idea that there were universal elements to language which are independent of culture and exposure. But he also was interested in the idea of what the evolutionary origins of language are. That's not a prime purpose of his work, but he's made the argument that in contrast to most of the other intellectuals who grapple with this, who've talked about how language helped us to collaborate better and language helped us to bond with our children and all this. Chomsky says, no, language primarily serves a completely different function. Language is like the software of the brain, and 90% of our use of language is completely internal. So it's
internal, our inner conversation.
In our own mind, and the whole nature of memory, the nature of planning and feeling and remembering is all contingent on our having words in our mind that we can use to store ideas and to contemplate the future. And so I bring this up in part because Chomsky became friends with Leonard Bernstein, the great musician, and my course is organized around a set of lectures that Leonard Bernstein gave in 1973 called the Norton Lectures at Harvard. And Bernstein tried to take the ideas of Chomsky and extrapolate them to music and to understand musical grammar and universals of music. And so, getting at the question that you're asking, it's fascinating to me that it's very difficult to keep more than one song in your brain at one time. The mind becomes, a lot of us have music going through our heads all the time. We wake up with some tune in our mind.
I'm guilty.
And, the classic thing is the brain worm, where you get the Gilligan's Island theme song in your mind and you can't get it out. And I think that this is relevant to the whole question of spirituality in music, because when you put people into a synagogue or church setting and you have the choir start singing, it cleanses the mind of any other musical influences and a lot of other things that we might be thinking about. So music serves as, in the words of Aaron Copland, as a currency of our emotions. And I think that in the church, the liturgical setting, it serves to bring everybody into a synchrony of mind and emotion, which helps to prepare them for whatever's going to happen there that day.
Yeah.
And there's, the whole idea of being open to the divine is, I think, something that's opened up very much by music, because you never know quite what's going to come next in the next bar of the piece that's being played. And so there's a whole literature of this, why music opens us to the experience of the divine, but I think it does.
I think I may have told you the last time I was at the Vatican, I was invited by Pope Francis to Sunday Mass in the Basilica. And it was an incredible experience, as you know. And as I was walked into my seat and I sat, and then the choirs began singing. And with the acoustic and just this incredible a cappella sound in this basilica. And I think about what you're saying, it's cleansing the mind. It's creating a different headspace, we would say. It's also getting you ready for something that's going to follow it, which was the Pope's words. So in many ways, it was choreographed. It was like an overture, a musical overture to what he would say, the message he would deliver. And I think about, as you say, different wisdom traditions, religious traditions that I've experienced where music is a part of cleansing. There's a Hasidic word that you might be familiar with called a nigun, and a nigun is a melody without words. And I love the idea that it's a melody without words, because words are so shrunken and small, and yet the melody isn't. And I feel like what it does is it gets you into a different state of mind so that you can be in a different state of worship or prayer. So you'll hear, like even from Fiddler on the Roof, yabba bidi 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 bum. This kind of thing is a nigun. Ya la 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 la, yabba ba 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 ba. And it's just using baby language, essentially, syllables, putting them together with melody to take us out of the book and out of the workplace and out of the concerns, and to bring us to a place where we're ready to pray.
I think that's beautifully expressed. And one of the things about faith that has been so important to me in my life is that I come from a Catholic family. My both of my parents were very devout Catholics. And I can't help but feel when I'm sitting in church that I'm connected to generations of my family that have gone before through something that mattered to them in a way that you can hardly think of anything else in our lives that connects us as directly to the emotional life and, the priorities, the salience of the previous generations that came before us. So I feel like there's this vertical connectedness that being in a liturgical setting creates, but it's also a horizontal connectedness to know that there are people all over the world who are experiencing what I'm experiencing right now.
Right.
And that's something I share. And I think I may have told you that I had a wonderful, amazing experience in 1997. I was the doctor on an archaeologic dig in the Golan Heights.
Right.
And just being able to be there and, explore the lives of these people going all the way back to the Bronze Age and to find religious artifacts, for instance, and to know that the things that matter to me also matter to them.
Yeah, it is powerful. I often think of that sign of a cross, essentially. I often think about the fact that when women traditionally in the Jewish tradition are lighting Shabbat candles, they are connecting to the woman and the woman and the women and the women before them who did at the same time of day, the same physical act, and said the same words and brought in a time of sacredness. And then I think about that idea horizontally. I think about it the same way that you do. The people in time zones all over the globe are doing the very same thing. That's incredible. If we lend our minds to that and our hearts to that, we're so much more unified and get a greater sense that what we're doing matters and has weight and is worthy not only of them, of us, and of being carried to the next generation. I could talk to you for hours. If my son, our producer, was right next to me, he'd be sending me an alert saying, you need to wrap up. I'll see you soon. It'll be over coffee, most likely, or a meal, and we'll continue our conversation. I just want to thank you so, so much.
Wonderful speaking with you, Ron.
A real pleasure. Thank you.
This season is produced and edited by Jonah Lee Paz. Content editing by Bronwyn Lee Paz. Musical theme by Amutz Plesner. Logo art by Janice Rudnitsky. Graphic design by Gusta Lee Paz. Social media management by Morgan Shanahan and Sophie Bergeron. The Meaning Mindset with Rabbi Ron is hosted by Rabbi Ron Lee Paz. Find us wherever you find your podcasts.